Hello and welcome to our webinar to EEG and Beyond, Exploring the Boundaries of Home Sleep Testing. This event is produced by Sleep Review and sponsored by Knox Medical and General Sleep. Home sleep testing devices typically focus on respiratory and cardiac signals. Technology improvements mean more data, including brainwaves, can be captured outside the sleep lab. For example, several of today's home sleep testing devices include patient-applied EEG electrodes and/or incorporate algorithms to provide data on sleep staging and arousals. I'm Cheree Roy, editor of Sleep Review. Today we're going to learn from Audrey Wells, MD, Cheree Scholl, BS, RPSGT, and Christopher M. Cielo, DOMS. Submit questions for them via the Q&A box. They are going to help us understand advantages of home sleep testing devices that provide more than respiratory and cardiac data, including implications for special populations such as women and children, feasibility of patient self-application of additional sensors such as EEG electrodes and leg movement sensors, and HSC limitations, even with the additional sensors and advanced algorithms. The slide deck is available for PDF download in the handout section of your control panel. Also in the handout section is a resources handout, which includes additional information on today's topic. Tomorrow, you'll receive a link with a recording of the webinar, so you can re-watch it if you missed any points. Also, many of our previous webinars are archived on our YouTube channel, youtube.com/sleepreview. I want to thank our sponsors, Knox Medical, available at knoxmedical.com, and General Sleep, available at generalsleep.com, for making this event possible. Stay tuned for more information about their home sleep test offerings. I am now pleased to introduce Audrey Wells, MD. Dr. Wells is board certified in pediatrics, sleep medicine, and obesity medicine. She is the founder of Super Sleep MD, an online platform for education, support, and group coaching experiences specifically for people struggling with obstructive sleep apnea treatment. Welcome, Dr. Wells.
Thanks, Cheree. Are you able to hear me okay?
Yes, I hear you great.
Awesome. Well, let's get started. Great. Today, I'm going to discuss home testing, and I'm primarily going to focus on women. Now, currently, home sleep testing most commonly takes place with a type 3 device, and I like to take care in how I describe it because a type 3 device really only tests for sleep apnea. So it's a home sleep apnea test, or HSAT. Home sleep apnea tests have greatly improved access to testing, which is hopeful in the face of the 80% undiagnosed sleep apnea disease burden. And of course, our population is getting older and gaining weight, but it's worthwhile to take a closer look at women in the context of home testing. As a card-carrying member of this group, I want to point out that women have only been regularly included in sleep research studies since 1993. And when it comes to obstructive sleep apnea, the middle-aged man with a thick neck and snoring is sort of the poster child for OSA. Screening and in some ways testing has been built around this endotype, and a lot of times it's a slam dunk to diagnose sleep apnea and prescribe PAP so you can improve the daytime functioning and stave off AFib and heart attacks. But much like heart attack symptoms, women with sleep apnea present differently. There's a higher prevalence of symptoms that are considered atypical when compared to men. So women have sleep onset or terminal insomnia. This may be their experience of sleep apnea, or it may be coexistent with sleep apnea. Women commonly describe disturbed or unrefreshing sleep, and also some symptoms that may be tangentially related to sleep problems, such as anxiety, depression, headache, and mood changes. There are sex-related differences in sleepiness measurements. In fact, for women, the Epworth Sleepiness Scale is not as predictive of the degree of daytime impairment associated with sleepiness, and women tend to report more tiredness as opposed to sleepiness.
Dr. Wells, sorry to interrupt. Can you accept screen sharing, because I think we're not seeing your slides moving. I think we're not seeing your slides.
Oh, sure. How's that?
There you go. Perfect. Okay, that's great. Go on.
Okay. So I was talking about the presentation of tiredness being more common for women and viewed as less specific for a sleep-related breathing disorder. Interestingly, the citation on this slide here is for a study in a population-based sample that found up to 40% of women in that group with an AHI more than 15 did not report any of the classic OSA symptoms, such as snoring, witness apneas, and daytime sleepiness. There are also psychosocial factors to be aware of when considering sleep testing. So women tend to come to medical appointments on their own, whereas men more often come with a partner. And in sleep, the bed partner report of symptoms can be very informative. Snoring may carry a stigma for a woman, and she may be reluctant to talk about it or even accept that she snores or gasps or chokes during sleep. Therefore, the clinical history is affected because symptoms are downplayed or absent. So this may affect whether or not a sleep test is ordered. It may affect what type of sleep test is ordered, and also how the results of the test are framed within the clinical context. And just like men, women can be resistant to accepting a diagnosis of sleep apnea and grab onto a negative home sleep test as a final result, despite the fact that they have a higher chance of a false negative. So why is that? Why are women at higher risk for a false negative result? Well, in addition to different symptoms of sleep apnea, it's also common for women to look differently on tests for sleep disordered breathing. This is attributed to lower loop gain, less airway collapsibility, and a lower arousal threshold. This means it's common for women to have more hypopnea events or partial airway obstructions as opposed to apneas. Also, more 3% hypopneas compared to bigger drops in blood oxygen. And one study has shown that this difference led to an average of 40% lower AHI in women versus men when the 4% DSAT criteria was used. And women have more hypopneas associated with arousal instead of blood oxygen desaturation. Women can also have more flow limitation associated with arousals from sleep. These are the respiratory event-related arousals, or RERAs. And since the RDI includes the RERA count, the RDI may therefore be much higher than the AHI. So it becomes very important to get the scoring of hypopneas right for women being tested for sleep apnea. And this is where home tests that do not measure arousals from sleep or are not sensitive enough to arousals will lead to a greater misclassification of disease, especially in that lower AHI range. For a type 3 HSAT test especially, this can easily translate into a false negative test or underrepresentation of severity. It's important to look at REM sleep too, since women often have more frequent airway events during REM compared to non-REM, even about the same as men in that particular sleep stage. So if REM sleep time is low, the overall AHI is effectively diluted with non-REM. And this affects women disproportionately anyway, because the total AHI predominantly represents the non-REM AHI. REM-related OSA is independently associated with adverse health outcomes too, including prevalent and incident hypertension, carotid intimal thickening, and cardiovascular disease overall. So women are more vulnerable to this if their sleep apnea is untreated or even undertreated. I want to show a few clinical challenges to describe these different female endotypes. So the first is the situation where it's a rare thing, a tired woman, maybe with some description of insomnia, whose in-lab study shows an AHI of 5 and an RDI of 35. Or another woman with an overall AHI of 5, but a REM AHI of 55 with only 30 minutes of REM sleep captured on the night of the attended study. Or a woman with Medicare insurance who is also symptomatic and has an AHI of 4 with the 4% DSAT criteria applied, but an AHI of 30 with the 3% DSAT criteria. And then if you do sort of a thought experiment and pretend that a type 3 home sleep apnea test captured that same night of sleep for each woman, you can see that the first and second ones may be on the fence for treatment, since the respiratory event index, which is the AHI surrogate on the home test, is really only borderline abnormal. And for the third case, she may not get treated at all, since only the 4% hypopneas are recognized. So in that case, she will have to get worse before she has even the option for treatment. Finally, if you take the hypopneas on the attended in-lab sleep study and separate the ones with DSATs from the ones scored with arousals, you can see that the arousal hypopneas, again, more common in women, would be in the blind spot on a type 3 home sleep apnea test. So in this example, the sleep apnea severity would again be underrepresented. And the severity is used to inform treatment options and may open the door to no treatment because their sleep apnea was deemed not that bad. Women are more likely to have coexisting insomnia with sleep apnea, which is also known as COMISA. And this can be problematic if EEG is not measured. The reason is that the total number of events is divided by recording time, which may be much greater than the sleep time for a woman who lies awake at night, or divided by the device's estimated sleep time, which may be high. In either case, the denominator is higher, and so the AHI gets diluted. In fact, coexisting insomnia is a reason not to have a type 3 home sleep apnea test. And a type 2 test that does measure EEG may be much more helpful in this situation. The research data currently available suggests that although the prevalence and severity of OSA may be lower in women than men, at least as currently defined, the consequences of the disease are at least the same, if not worse, for comparable degrees of severity. So perhaps women should have a lower threshold for sleep testing. And I think there's also an opportunity here to educate and try to recruit insurance payers to this idea. Moving to type 2 devices that have arousal sensitive EEG and possibly even eye channels for REM scoring is one way to improve. Multi-night testing may also help to get a better sample size and identify patients at risk. And longitudinal testing is probably indicated to treat sleep apnea like the chronic disease that it is. But also, to screen women in a timely way during periods of hormonal shifts such as pregnancy, perimenopause, and menopause. I want to at least mention the issue of sleep apnea in pregnancy here. This is a time of massive physiologic change in a woman's hormones, blood volume, and fluid distribution, not to mention changes in breathing as the baby grows enough to press up into the chest cavity. Snoring is commonly reported in the third trimester, and studies have shown about 8% of women have some degree of sleep apnea in the second trimester, and obstructive sleep apnea is even more common in women who have obesity. This increases risk for hypertensive disorders of pregnancy and gestational diabetes, and can affect the outcomes of the pregnancy for both the mother and the baby. Since this is a time-sensitive situation, I think planned screening would go a long way toward helping this problem. And it's easy to see how home sleep testing could play an important role in that. Home testing is really helping with access to diagnosis and is typically more convenient and more affordable. But I think we're still in a state of learning about the limitations and interpretation in certain clinical contexts. I hope I've made a good case for some of the nuances of testing women and how the type of test matters for accurate diagnosis and treatment. We really need to get hypopneas right and also be sensitive to REM-related sleep apnea as a significant clinical entity. Home testing also offers a choice to a patient, even if that choice is often influenced by the patient's insurance, and I think that's empowering. It's actually my preference to call a home sleep apnea test inconclusive if it doesn't show sleep apnea, and also to do some anticipatory guidance for that result in the initial clinic visit. I'll be excited to see how the different type 2 devices perform and also what other biometric data could be useful going forward. And with that, I'll end my presentation and let you know that I've included a list of references that will be available in the materials after this webinar.
Thank you, Dr. Wells. I'm also a card-carrying member of that population, so I really appreciated that. And I liked what you said about calling it like a blind spot of certain testing. I think that's a good analogy. Let me share a message from our sponsor, and then we will move to the next presentation. Let me make this a little bit larger so everyone can see. Okay, but thank you. That was excellent. Before our next presentation, here is a message from sponsor Knox Medical. Knox Medical is a sleep technology company that offers trusted home sleep testing and polysomnography solutions that come with an AI-powered sleep scoring software. The company's flagship PSG sleep testing system, the Knox A1S, is versatile enough for use in the sleep lab and in the patient's home, designed for accuracy anywhere where sleep testing is needed. Driven by a passion to help provide the most accurate diagnoses to all patients, Knox Medical is committed to making sleep care comfortable, accurate, and accessible to all. I am now happy to introduce our next presenter, Cheree Scholl, RPSGT. She has an associate's degree in polysomnography and a bachelor's degree in neurodiagnostics and sleep science. She is employed by Clear Lake Sleep Center as the manager. Welcome, Ms. Scholl.
Hi, good afternoon, everyone. Well, it's good afternoon in Texas. As Cheree said, I'm the manager for Clear Lake Sleep Center. I've been a sleep tech for 10 years now, and there's definitely been a growth in the differences in at-home sleep studies. Today, I'm going to be talking about the at-home sleep study devices that monitor EEG, also known as type 2 HSTs, and the ways that our sleep center staff set our patients up for success. So as Dr. Wells had said, it's commonplace for most sleep centers to utilize type 3 and even type 4 home sleep studies. Type 3 devices monitor a minimum of 4 channels, typically respiratory effort, airflow, and pulse oximetry. Type 4 devices monitor even less channels than that. When these at-home sleep studies are used, like Dr. Wells had also said, AHI is calculated by time in bed versus an actual sleep time. Many people spend time in bed watching TV, playing on their phones, reading, which can lead to inaccurate results. Being able to incorporate EEG data to measure sleep and wake stages alongside respiratory channels allows for an AHI to be calculated based on actual sleep time. The end result is an AHI that is not diluted by wakefulness. Type 2 HSTs show clinicians the type and severity of sleep apnea. Many challenges that we may face when more channels are integrated, like EEG with at-home sleep studies, is keeping the process as minimally cumbersome to the patient as we can. Keeping the process simple and allowing for a higher quality data is key. There are more than 2 or 3 type 2 HSTs on the market today. For this presentation, I will just be touching base on the device our sleep center uses and 2 other ones. The device that we use is the Synergy Z machine by General Sleep. The EEG sensors are snap electrodes with adhesive and conducting gel already applied. They are applied by the patient on the mastoids and at the base of the neck. Additional respiratory data is gathered from a pressure transducer, rip belts, and pulse oximetry. Here's a sample screenshot of a study. You can see all of your commonplace respiratory channels at the top and the additional EEG channels with the sleep staging towards the bottom. Different sleep manufacturers acquire their EEG signals differently. This is the Sleep Profiler RPSGT by Advanced Brain Monitoring. The EEG sensor is applied to the forehead instead of the mastoids. As you can see, the study layout is very similar to the Synergy machine, displaying sleep stages at the bottom. And you can also see the respiratory belts, and it looks like this one also does chin EMG. Next, this is the Aries 620. The EEG sensor is also applied to the forehead. This device measures SpO2, EOG, EMG, heart rate, head position and movement, snoring, and optional respiratory channels. So when I was hired on to be the sleep lab manager, and I learned that some of the at-home sleep testing devices that were used were able to capture sleep staging with EEG, the former night tech in me wanted to know how. I only have some knowledge of how this is done with the Synergy devices that are used by our sleep center. For the Synergy device, it uses a single channel EEG with 2 exploring electrodes and 1 ground. The EEG signal is processed with a machine-based algorithm that is capable of learning to determine the sleep and wake stages. The EEG is then processed a second time where the algorithm will differentiate between sleep and determine if it's stage 1, 2, 3, and REM. When we can use at-home sleep studies with EEG, it allows for more quality clinical data to be gathered. Clinicians can get a bigger clinical picture. With EEG added to HSTs, you're able to capture data similar to a PSG. Reports show an AHI based on sleep time, latencies to various sleep stages, and wake after sleep onset. And this is just an example of an EEG report from the Synergy devices. Various sleep reports are available with these devices that show respiratory right alongside the EEG. I know one of the physicians I work for likes to be able to show his patients the graphs. He likes to demonstrate to them how fragmented their sleep actually is, because a lot of patients may not realize it, and they get to see the big picture about their sleep disordered breathing. So how do we accomplish this and keep it simple for a patient to be able to do this? For the Synergy device, patients are provided a individual alcohol prep pad, what they use to clean the skin for the EEG electrode application. The EEG sensors are prepackaged in sets of 3 with directions also on the packaging to apply the sensors to the prepped skin. Patients need to be educated on how to apply the EEG sensors correctly and how to use the device. This is key to their success. Here are some additional steps that Clear Lake Sleep Center takes to ensure that we get the data that we need and we stay time efficient as well. When patients come in for their appointments, they're given a video card, as you can see on the bottom right. They'll press play on the video card and it'll show them video instructions on how to use the device. And then when they're finished with that video, we take time to hit the key points for them to remember when they go home and apply it to themselves, like proper EEG application, the nasal cannula application, and the pulse oximeter application. And we also make sure to ask them before they leave. If they have any questions, we want to make sure they're not leaving our sleep center not really knowing what they're doing. We want to make sure that they're good to go. We also have these clear luggage tags that we have attached to our carrying case for our HSTs. And on those tags, we have a QR code of the patient guide and video instructions in case they feel like they need to re-reference that. We also provide a hard copy of the patient instruction manual if the patient feels like they need it. With my presentation, you were shown how EEG recording being added to HSTs increases the quality of the data received, which leads to an overall higher quality in patient care. And ultimately, that is the end result. We want to make sure our patients are getting taken care of properly. And that there are steps available that can be used to ensure that patients have success when being able to do an HST at home that incorporates more channels.
Excellent. Thank you so much. I love that luggage tag solution with the QR code. We now have a quiz and a sponsor message from General Sleep. Let me pull the quiz up first. Okay, if everybody could take this. The quiz. Why is EEG sleep staging an important part of an accurate home sleep test? Enables calculation of true AHI value for apples-to-apples comparison with sleep lab studies. The AHI is more accurate because it is based on EEG sleep time and not time in bed. Sleep staging information is revealed, which can report on light sleep, slow wave sleep, and REM, or all of the above. Okay, we've gotten a good number of people who voted, so I'm just going to give another few seconds. We will close the poll. I will give up the result. We'll do a sponsor message, and then we will move on to our third presenter, and then we will move on to the Q&A. I see a couple of great questions that have already come in. Okay, most people have voted. Let's share our results. Excellent, and the correct answer is all of the above. So most people who took the quiz got it correct. And the people who voted for more accurate AHI, that is correct, but it also does enable the calculation of the true AHI and the sleep staging info. Thank you, General Sleep, for that poll. Let me now share my screen. So how do I close this one? Well, let me see if I can just share my screen so that we can do the sponsor message and move on to the third speaker. And I still have the poll results on my screen. 1 second, hide results. There we go, that should do it. Okay, message from General Sleep. General Sleep is a technology-driven company that is dedicated to providing innovative products that enable medical and dental professionals to achieve maximum effectiveness in the diagnosis and management of sleep apnea. We believe doctors should have a complete picture of their patient's sleep, not just a portion of it. General Sleep manufactures the home sleep test that we would want used on our loved ones. Working together and with the assistance of our Z-Machine synergy, every doctor will have the clinical information they need to make the best treatment decisions for their patients, because every patient deserves a comprehensive level 2 home sleep test. Now I am happy to introduce Christopher Cielo, who is a pediatric pulmonologist and sleep medicine physician at Children's Hospital of Philadelphia and assistant professor of pediatrics at the University of Pennsylvania. He is the director of the CHOP Sleep Center, where he sees patients and has a particular interest in children at increased risk for obstructive sleep apnea, such as those with Down syndrome or craniofacial differences. Welcome, Dr. Cielo.
Thanks. Thank you so much for the invitation. And it was really great to hear the first 2 speakers. Hopefully this complements it well. I don't have any disclosures, but I do have some funding from NIH and American Academy of Sleep Medicine Foundation, and I will be talking a little bit about some of the projects related to home sleep testing in kids that were funded by those organizations. So these are the objectives, which I'm not going to read out. I think you have them in the handout, but I hope that by the end of this talk, you'll have a sense of how we evaluate obstructive sleep apnea in children, some of the benefits and limitations of the way we're doing things now, potential benefits and limitations of home sleep testing in that population. So for those that are primarily adult focused, sleep apnea is actually one of the most common respiratory conditions in children, affecting as many as 5% of kids. And in our sleep clinic and many other places that are evaluating children for sleep apnea, there certainly are a number of high-risk conditions, including obesity, which we're seeing more of, kids that have enlarged tonsils and adenoids, as you can see in this image on the left there, children with craniofacial conditions like this boy in the picture with hemifacial microsomia. We see a large population of kids with Down syndrome, all of whom should be assessed for sleep apnea, as well as other things like hypotonia, children who have a history of prematurity, and there are many others. And in kids, what we see primarily is reduced quality of life, neurobehavioral deficits, and their associated metabolic and cardiovascular changes. This is a figure from data from the childhood endotonsillectomy trial. This was one of the subsequent papers that looked at both that looked at a number of quality of life measures, including the PEDS QL and some others, showing that after treatment with adenotonsillectomy, there was significant improvement. And unlike in adults, the first line therapy in most children is adenotonsillectomy, and more than 300,000 adenotonsillectomy surgeries are done every year just in the United States, just for obstructive sleep apnea. So there are big implications regarding access to assessment for that condition and whether or not the surgical intervention is successful. So the most recent published clinical practice guidelines from the American Academy of Pediatrics are actually more than 10 years old now. It's hard to believe. And these looked at one of the key action statements included the assessment of obstructive sleep apnea in children. And actually the only key action statement that came out of that entire guideline that had evidence quality A was for polysomnography for the assessment of OSA in children. That's on the left side here. So kids who have snoring or other findings that are shown in this table should be assessed using PSG. Even at that time, they did actually mention ambulatory polysomnography, but it had a very low evidence grade. And so it's generally not done in the United States as part of the assessment for sleep apnea in kids. I think one of the main challenges has been just access to sleep laboratories. And so you can see in our lab, we do about 350 sleep studies just in children every month. But the wait time right now in our lab is about 280 days, which is really too long. And we've had a number of kids who have very, very severe sleep apnea that are waiting a long time. And even in places, that's even in places like Philadelphia where I'm located, and we have a rather large pediatric laboratory, but there are many places where polysomnography just really isn't available, especially for kids who have a lot of special needs or for very, very young children. They may have very limited or no access at all. So that's a real challenge. In addition to that, there are other costs and limitations associated with in-lab polysomnography. So the test can be expensive, both in terms of setting up a laboratory, expanding a laboratory that exists. There are expenses associated for the family with high copays. That can be a challenge. It's also inconvenient. We see many families where there's a single caregiver and multiple children who are not able to come in with the parent for the test. So that's difficult for them sometimes to schedule. And it can be very stressful for children. We're fortunate where I am to have a really dedicated group of technologists who are comfortable dealing with autistic children and kids with Down syndrome, infants and other difficult populations, but that's not always the case. And even in some cases when you have a very patient technologist or staff, some children really have a fear of coming to the hospital because of other medical conditions they've had. So that in-lab testing can be a challenge for that reason too. So home sleep apnea testing is sort of an obvious alternative, and as you've heard from the first two speakers, is used commonly in adults. And you might wonder what research has been done in children. And actually, there have been testing using home sleep testing with EEG in children that dates back to the 1990s. There are two references here. The second one, the Goodwin reference, is from a study that was called TUCASA. And both of these studies included almost 200 or around 200 children who were being assessed for sleep apnea using home sleep testing that included EEG. And I've included a table here from the Marcus study, which was a study that looked at school-aged children, 5 to 10 or so, who had a history of prematurity and were high risk as part of a randomized controlled trial. So they underwent unattended ambulatory home polysomnography. Now these were set up in both of these studies by a technologist in the patient's home. And both of them had identical technically adequate studies, or 91% was actually in both of these studies, which was very surprising, and they were really good. And in both of the studies, the nasal pressure signal was the most problematic. And you can see in the second and third columns here from the Marcus study that the recordings that had a greater than 95% accuracy throughout the study were most of them. And you can see the percentage. In the box there is the ones that had the nasal pressure flow. And then if you go back to 75%, you have even a higher percentage. So showing that there really was good feasibility. Now, what neither one of these studies did was look for reproducibility compared with polysomnography. So that was a big limitation. That wasn't the design of either of these studies. And throughout the COVID-19 pandemic and even beforehand, there have really been an explosion of studies that have looked at type 3 testing, as you've heard kind of referred before, without EEG, as I'm calling it here. This is one study by Amy Ravana from the Baylor Texas Children's Group. And so she looked at a small sample size, 38 patients, and these were mostly adolescents who are coming in through their obesity clinic for assessment for OSA. And this was done kind of in the early days of the COVID-19 pandemic. And what she found here, I think, is emblematic of a lot of the studies done in children with this type of testing, which is that you're going to capture the most severe cases pretty easily, but the type 3 testing is really significantly underestimating the severity of sleep apnea. And that's important in kids particularly because we have much lower AHI cutoffs that we use in terms of treatment. So you can see here that the mean difference between the two types of tests, this is home sleep testing type 3 versus in-lab PSG, was about 15. And that's basically the difference between like no sleep apnea and moderate to severe OSA in kids. Just one more study here to mention with type 3. This was done by David Gazal and his group before COVID, but basically they just took the actual signals from the in-lab test, and then they took away the signals that would make it like a type 3 test, so EEG, the EOG, and the EMG signals. And they found that by just doing that one thing with identical numbers, so there's no night-to-night variability, they miscategorized about a quarter of them. And again, they said that this is because of the inability to distinguish between sleep and wake and score the events that result in arousals. And again, this is what you heard from the previous two speakers too. So the American Academy of Sleep Medicine had a position paper that came out in 2017 that accompanied their paper with adults that basically said there really was not a lot of evidence that compared home sleep testing to in-lab polysomnography. And at the time, all the studies they reviewed, there were only like nine participants at that time out of like 450 that this had been done. Most of the studies that they reviewed didn't involve any type of EEG monitoring. And importantly, in pediatrics, most of those studies actually excluded children with comorbid conditions, which is a high proportion of the kids that we see. And they talked about a number of other factors, including parent and child success features. So I'm actually vice chairing a new group through the AASM that's revisiting these guidelines, and we've just started meeting. It's a really great group. And we think that in about 3 years, we're going to have a revision of these guidelines just because there's been so much more data that's come out. So that's really exciting. So you've heard this mentioned already. I'll just show a snapshot from one of our research studies. Obviously, an advantage is that you can tell when the child is asleep when you have a sleep study at home that has EEG. And so this is an example of one of the children in one of our Down syndrome studies. And you can see this child had a hard time falling asleep on the hypnogram here that's in this box. The child's awake for that whole time. So we're not going to score any of the respiratory events. And then I'm not showing it here, but obviously we in pediatrics will have many events that are scored because of arousals. And when we have the EEG, that's very easy to do. And it's easy to train somebody because they've already been doing this in the lab with their in-lab polysomnography. Just going to mention a few of the studies that we have going on briefly. The HSAT-DS is a study that we've done that was just accepted for publication in Journal of Clinical Sleep Medicine. I think it's on their website, but not in PubMed yet. We did a small pilot study, which I'm not really going to review, and then we have 2 ongoing clinical trials looking at home sleep testing in kids. So one of the things that we did, and this is similar to what you heard Cheree talk about, and it sounds like she has some really great resources. We anticipated some of the same issues in our population, and we actually went ahead and made some videos that were posted on YouTube that you could find. And then we have these storyboards that we developed, particularly because we were starting with kids with Down syndrome that can be challenging both for the kids and the parents. And that stuff that Cheree made sounds fantastic, and I want to check it out. But we have done similar kind of stuff too to help with families along the way. And so the study design for all of these is very similar. We're looking to evaluate feasibility, looking at parent and child preference, and assessing the accuracy of the home sleep testing versus PSG. So they come in on one night and have the PSG as part of their clinical care, and then they come in a separate time to get set up for the EEG for the home test. They go home then after being set up and have the test at home, and then we have the kit picked up, and we have them complete a number of questionnaires. So we did this pilot study, as I mentioned, that involved just 15 kids. We looked at kids as young as like under 3 and some that were teenagers. We were just trying to get a sense of how this would work in children. And we had a pretty good representation in terms of sex and race and ethnicity. And it was kind of a mixed bag. We had some families who preferred the in-lab test. We had others who preferred home sleep testing. And this is kind of what we anticipated. we don't see this as something that's going to replace in-lab polysomnography, but rather be an alternative. And this was looking at the accuracy. Again, it's a very small study, but we had a very tight correlation. Our R was 0.9. And out of the 15 kids, the home sleep test was able to correctly identify 14 out of 15. It was just one with very mild OSA that was miscategorized. And importantly, we used an AHI cutoff of 2, so it's very strict. We're not just capturing severe sleep apnea here. We wanted to sort of get even the mild ones. So we were able to get some funding, my colleagues Ignacio Tapia and Andy Kelly, through this Include initiative that funds a lot of Down syndrome research from NIH. And we recruited 43 youth with Down syndrome for the study. Again, you can see the race and ethnicity. They had a very high prevalence of medical, psychiatric, and behavioral comorbidities, but that was sort of intentional. We wanted to pick really challenging kids. And again, they came in and did the test. Out of the 43 that we recruited, 40 were able to complete all the procedures. We were really proud of the families and our team for being able to get them through that. And we found a little bit of a different picture, and this is the paper that just got accepted. Almost all of the families found that the home sleep testing was easy to use, was appealing, they had a positive impression of it, and a much higher proportion actually preferred the home sleep test, which you can see in the dark color here, compared to in-lab polysomnography. And again, that was a little bit of a surprise, but when talking with families through some structured interviews, some of those even that had really high compliance, for example, with CPAP, really had a hard time with the PSG in the lab. Again, even with our really good pediatric staff. So that was kind of encouraging. And then when we looked at accuracy, we found a very good correlation again with these more challenging patients. And you can see here like the correlation was pretty good. The one thing we did find that was kind of a little concerning was that 15 of the 43 patients had sleep-related hypoventilation, and we were not measuring CO2 with this test. So that's certainly one of the limitations for our study design. And we do have, as I mentioned, several ongoing clinical trials. We got funding for a much larger trial through NIH that's called the HATCH trial. It's registered on clinicaltrials.gov. And it's a similar design where we're going to be recruiting about 300 kids to do in-lab testing, as well as the home sleep testing with EEG. They'll be between ages 5 and 12, and we will include really kids across the whole developmental spectrum with as many comorbidities as we can get. We're pledging to have 100 kids with Down syndrome in that study because we want to really represent the kids who actually come in for sleep apnea evaluation. And then we have one other trial that we're doing that we're calling Home Kids. That is looking, this is funded by the American Academy of Sleep Medicine. This has only involved 60 kids. And we're going to be looking at how well the home sleep testing could be used to assess treatment after adenotonsillectomy. So these kids that have adenotonsillectomy but still have symptoms, could home sleep testing be a way to reassess those kids? And we've already recruited, I think, 25 kids for that study. And these studies have been really easy to recruit for. Families are really, when they hear about it, they're very excited to try out the technology and I think, have the opportunity to do this kind of test. So we're really grateful to the families of the kids that we see in clinic. So in summary, I'll just say that in-lab polysomnography is really what's currently recommended in the United States, but there really is nowhere near the capacity to evaluate all the children with sleep disorder breathing. I just came back from the American Thoracic Society conference and was doing a few sessions with some colleagues from Belgium and Canada and other places, and it's interesting to hear in other countries the access to this type of testing, and obviously it's different. So in some ways we're a little bit behind in the US, but in other ways we have some more access to certain facilities that may be more challenging there. There is certainly growing evidence that home sleep testing is feasible, and it can diagnose moderate to severe sleep apnea. And again, I think what we're interested in is whether or not it can be an accurate assessment and really a true alternative. And then I guess the other thing is just sort of which sensors we would need in order to effectively evaluate sleep apnea in children. So with that, this is just to thank the different funders and been a lot of different team members who have helped us with these studies. So thanks again for allowing me to be a part of this session.
Thank you, Dr. Cello, for a revealing and fascinating presentation. As a mom of 2 young kids, I'm definitely passionate about access to care for children. We are about to begin the audience Q&A. So if you haven't already, please input your questions into the Q&A chat box, and be sure to take the course evaluation, which will appear after the webinar ends. Here is one final audience poll. Why haven't you adopted at-home PSG at your facility? Select all that apply. Give you all a few more seconds to take that poll. The options, which you can select all that apply. My current PSG equipment is not able to perform at-home PSG. Insufficient published clinical evidence. My sleep lab can meet the demand for in-lab studies. Lack of reimbursement, or we've already adopted level 2 at-home PSG. Okay, let's close this poll and share the results. The 57% said lack of reimbursement. 39%, my current PSG equipment is not able to perform at-home PSG. 26% have already adopted the level 2 at-home PSGs. 22% insufficient published clinical evidence, and only 4% say my sleep lab can meet the demand for in-lab studies. Thank you for sharing that information. Let me share my screen a little bit larger, and let's dive in to the audience Q&A. We've got some great questions. The first question is from Thomas Spear, and I'll send this to Cheree first, but anybody can jump in after. Cheree, what is the sampling rate for EEG, and how long can you record the patient?
So I'd have to look into the sampling rate for the EEG. I don't have it in front of me. As far as how long the study goes, I know that that was a question I had because we do multi-night studies, and the devices that we use are chargeable. They don't require batteries. And I was informed that the device can record upwards of 30 hours before needing to be charged again. And I do see that with our devices that go out for 2 nights. Sometimes our physicians will do 3 nights, and we're able to capture the data from all 3 nights without any issues.
Fantastic. If anybody else wants to jump in, otherwise we'll move on to the next question. This question is from Karen Thayer for Dr. Wells. How do you work with women who have sleep issues but are resistant to getting a sleep test?
Yeah, that's a really common situation. Sometimes women are referred for health conditions that are aggravated by untreated sleep apnea or reduction in sleep. Sometimes they're coming in because of daytime symptoms and such. I take a lot of care to find out what motivates them to feel better, both in terms of their day-to-day health and also protecting their long-term health. And one of the great things about sleep is it's an opportunity to do preventative care, not just reactive care. So that's one thing that I think that a lot of people can understand and get behind. You know, you really want to treat sleep as something that can improve your overall health. And the choice of having a home sleep apnea test has an appeal for a lot of people, both women, men, and children. But educating them on what the limitations are and how well the test matches their clinical picture oftentimes goes a long way so that they can understand and make an informed choice.
Great response. We have a question for Dr. Cielo from Melissa Maloney. When are you hooking up the EEG for your HSAT patients? During the day with a day tech or having them come into the lab in the early evening and having an overnight tech do it?
Yeah, good question. And again, these are, just want to emphasize that these are research studies. So we're not using them for clinical care right now. The way we've done it is we have the families come in the late afternoon, and we have the kids come in their pajamas. So they're kind of like all ready to go for bed. So it's typically one of our team members who's there during the daytime before the patients come for their overnight studies. And so they hook up, she does the EEG and wraps their head. The family has already usually reviewed kind of what their responsibilities are, but as she's doing the setup, she'll talk with the family about troubleshooting the device. And then the cannula and the Bluetooth pulse oximeter the family can put on when the child goes to bed, but the belts are already in place. And we have the device that we use, which is the Knox A1 or A1S device. The families, we've already programmed it to start before the child goes to bed. We find out what time they go to bed. We start the device recording a little bit before that, and it records for 12 hours. So we haven't done any multi-night studies, but I'm interested in thinking about that for the future. So the family comes in, and we actually have like a courier service that picks up the equipment the next day because the devices themselves are quite expensive, and we don't want to rely on the families to return them.
Great. Cheree, I'll send this one to you. What is the reimbursed rate range for type 2 as opposed to type 3? What is the average difference of reimbursement in your center in Texas? That question is from Brendan Duffy.
All right, thank you for the question. I do understand the concern for that. So there's a lot of factors that do play into it. What codes you bill with. We bill for 95800 and 95819. So there's that. And then you also have facility or specialist billing. Because we're attached to our physician's clinic, it's a little different. We're not a separate facility. But for us, there was an increase in reimbursement rates, and I utilized that information to help our doctors decide to purchase more, because we do get quite a bit of people who do at-home sleep studying at our facility.
Great. And we actually have another question for you. This one is from Kristen Altmeyer. What is the greatest challenge you see in setting patients up with HSTs that use EEG?
The greatest challenge that I see, a patient's willingness to do the study. Across the board, I'm sure everyone's familiar with, not everybody understands why they're doing it, or they don't really care. They're just going through the motions. I think that honestly is the greatest challenge. When the patients come in and they're like, yeah, I've got to get this test done, and there's a willingness for it, the success rate is higher. But that to me, that's the greatest challenge.
Wow, that's really insightful. I'm going to send this next question to you as well. It's another question from Thomas Spear. How do you define pre-event O2 baseline saturation rate? How do you define pre-event oxygen baseline to determine desaturation?
So when I'm looking, because I'm the one who goes over our studies when they're brought back, when you're looking at the data from the device that we use, it's just like a PSG. You see the whole, you can decrease your time frame windows. It can go from 30 seconds to like 10 minutes, and you can actually see the drop in the O2 saturation just like you would in a PSG.
Great. And this might also be a good one for you, Cheree. It's from Heather Thompson. Can you comment on success rate on level 2? And actually, Sarah, I'll have you answer it, and then I'll send it to Dr. Chiala, because she also clarified that she's wondering about success rate in children. Yeah, we'll go to Cheree and then Dr. Cielo. Can you comment on the success rate of level 2s?
So we send out anywhere between 4 and 5 at-home sleep studies a day. And in a week's time, sometimes we don't have any inconclusive studies that come back. But I feel like the success rate is high. Again, it boils down to a willingness to participate in the study.
And then Dr. Cielo, can you comment on the success rate of the level 2s in children?
Yeah, I mean, I think it depends how you define success. And we've struggled with this a little bit just in terms of the setup of our research studies. And then we've thought about, well, how do we define it in, with an in-lab PSG? And I think it's certainly lower than in-lab PSG because, you're relying on the family of these children to replace the signals if they come off. We've had a very high success rate with EEG. We've had a very high success rate with the belts, like almost 100% in both of those. The pulse oximeter, we have had some challenges with. Some kids will take it off early part of the night and the parents aren't checking on them and don't put it back on, and we lose it for, I just was looking at one for like 80% of the study, we had no pulse ox. The cannula is the other one that comes out frequently. We've been looking at using some of the RIP flow signals as an alternative to scoring respiratory events when we've not had a flow signal. We use a thermistor and a nasal pressure signal. So, but in the really severe cases, you may only need a few hours worth of data, and you could probably, from a clinical standpoint, feel comfortable with the assessment. I think it's when it's more subtle or when it's a little bit more equivocal, it's when it becomes more challenging. So, this is why we're kind of comparing with in-lab PSG, I guess, directly. There's other stuff too, just like the night-to-night variability, and then how much weight do you really put on just this AHI, just this one number versus other factors. I think in pediatrics, that's probably going to change quite a bit in the coming years. There's a big trial that's going to be published in the next couple of months that may change how we weight some of these things. But I think the success rate, I would estimate based on those other studies that I mentioned was like about 90% for this type of test. I think ours has been maybe a little bit lower, but in that same ballpark.
Thanks for that information. We have time for another question or two. So if you have a question, please type it in now. And then Dr. Wells, I had a question for you. What additional sensors beyond EEG would you most like to see in future home sleep tests, and why?
I think leg sensors are something that could be added, especially if the clinical history is suggestive of RLS, PLMD, even REM sleep behavior disorder or other parasomnias. Adding that EMG component may be helpful.
Fantastic. And then Dr. Cielo, I had a question for you. Do you think we'll get to the point where home sleep testing is as prevalent among children as it is among the adult population? Maybe where only children with severe comorbidities will be coming into the sleep lab?
Well, in my ideal world, you'd have educated providers, whether those are people who are boarded in sleep medicine or otherwise, that knew the different types of tests that were available, knew the limitations of those types of tests. And this is across the whole spectrum of sleep apnea tests that are available now and those that haven't even been invented yet, including in-lab polysomnography, and could see the patient in front of them, know the resources that are locally available to them, know the family they're dealing with, and choose the best test that would help for that patient. I think, as we're working on these guidelines, revising these guidelines, we're mindful of the guidelines that were written for adults and how those have, been interpreted and how insurance companies have responded to them. So certainly would not want to handicap physicians who felt like an in-lab test or, providers who felt like an in-lab test was the best test for a patient, or a family who frankly didn't feel comfortable or could not do a home sleep test. So my ideal world, there would be like many, many, many options, and people would know those options, and or at least a few of them, kind of like you might with, say, asthma medications or something like that, and be able to choose the best one for that patient. I don't know if that's going to happen, but I'm just mindful that technology will continue to improve, and just because we're using a certain type of test now doesn't mean that, you know, that will be the best test for every patient or, you know, for the rest of time. So I think it's an exciting time, and I think we're going to see a lot of change, you know, as we kind of move forward.
Fantastic. Well, I would like to thank our speakers for sharing their insights today. I also want to thank Knox Medical and General Sleep for making the event possible. And to our audience members, thank you for your time and attention. You can join Sleep Review online at www.sleepreviewmag.com and on YouTube, LinkedIn, Facebook, and Twitter. Email editor@sleepreviewmag.com with comments, questions, and future webinar suggestions. You can also put those in the exit survey, which will come up as you leave today's webinar. And with that, I want to thank everyone for participating in the Sleep Review webinar.